So good afternoon, everybody. Thank you very much for coming to this seminar this afternoon. My name is Jeremy Dixon. I'm the Deputy Director of Exchange and a social work academic. This is part of the Adult Safeguarding Conference series, and it's the last session today. If you've missed the previous sessions, then you can catch up with them on our Exchange website. But I'm really pleased to introduce Professor Michelle McManus and Dr. Emma Ball. The title of today's presentation is Learning from Adult Practice Reviews. And Michelle is Professor of Safeguarding and Violence Prevention at Manchester Metropolitan University. She's led major national and international research on safeguarding, exploitation and violence reduction, and has worked closely with the government, police and safeguarding boards to influence policy and practice. Her work focuses on actionable recommendations, workforce development, and embedding the voices of those experiencing safeguarding. Emma Ball is a Senior Research Associate, also at Manchester Metropolitan University, and she's based in the Safeguarding and Violence Prevention Unit also. She's worked on and led qualitative analysis on national projects across England and Wales, and has researched the effectiveness of multi-agency safeguarding. She's led the development of the 5-domain national multi-agency safeguarding performance framework in Wales, the collective safeguarding responsibility model, the 12 C's and the recommendation I framework. And as a formal social worker and practitioner, she's passionate about improving outcomes for those within the safeguarding system. So before we kick off, I just want to say that a little bit about taking part. So we will have a presentation of about 40 minutes or so. So if you'd like to ask a question, that would be great. But if you can put it in the Q&A box at the top of the bar, that would be brilliant. That just helps us to keep track of questions. And if you want to make general comments to one another, you can do that via the chat box. If you're having any problems with the Q&A box, just let us know and we will help you out. Just to say that the normal rules apply, as with any kind of seminar. Please just treat one another with respect. And because today's presentation is one which focuses on adult safeguarding, it will, of course, feature discussions around abuse and neglect. If you want to know about the freedom of speech guidance that university uses, that's also will be posted online. So without any further ado, I would like to hand over to Michelle and Emma. So thanks very much for coming, and I'll hand over to you until the questions.
Brilliant. Thank you so much, Jeremy, and thank you for inviting us both. We've got a lot to cover today, and Jeremy's done such wonderful, which I'm so glad I recorded, introductions. We can keep them for a while. So hopefully everyone can see my screen and can hear me very clearly. So what we'll do is we're going to get cracking because we have got a lot to cover in a very short amount of time. So we are going to be kind of going through some of the key learning from our Adult Practice Review, which was commissioned by the National Independent Safeguarding Board, which we completed in 2025. And we're going to very quickly just go through sort of the key findings from that thematic review. We're going to spend a bit of time also talking about the recommendation I framework. This was developed on the back of the work within the APRs, and has actually taken on a bit of a life of itself, and hopefully will be useful for people in the room today for various things that you might be engaged with in your own work. So it's just something that hopefully will be helpful to a lot of people. So the first thing I'm going to do is I'm going to take you through some of the more descriptive statistics from the APR analysis, and then Emma's going to go into more of the detail as our qualitative lead in terms of the findings from all of those 25 reviews. Some key things just to note, which is obviously in terms of these incidents ranging from 2016 to 2022. And again, just the time range, which often is captured, and we'll talk a little bit about this as well in terms of how long the process takes, in terms of that incident notification, all the way through to actually the review being completed. So you can see all of these reviews are fairly recently completed from 2020 through to 2024. So just initially going through some of the risk factors and descriptive statistics in the APRs. So the first thing that I'm going to highlight in this slide from the 25 that we looked at was around the kind of extended and concise and historical breakup across the APRs. Now, obviously, the extended tend to be the more serious ones. They are tend to be given a bit more time and a bit more resource as well, and particularly because of the extent of engagement with statutory services prior to the incident taking place. And what we can see from this is that 17, so 68% of them were considered as an extended review, and 6 as concise, and 2 were historical. What's really interesting, and I talk about this a lot when we're going through this presentation, is that 84% of the sample had resulted in the death of the adult that we were looking at as part of that review. This is really interesting because having done the child practice reviews, this is actually higher, a lot higher than what we tend to see in child practice reviews, which the last one we did was around 64% resulted in the death of a child. So what this is telling us is that the result that we tend to see more than we do in children and adults is the death of that adult. Again, it's something to consider, and maybe some discussion points for later on as to why we're seeing such a higher proportion of adults resulting in death within the APRs, with only 4 that had been seen as sustaining that potential life-threatening injury or serious permanent impairment of health. So the age range was from 18 to 87. So we can see around a quarter of them were between 18 to 24 years, and around just over half were 60 years and older. So we are sort of still disproportionately seeing a slightly older age group in the majority of our data. The little star on gender is just to indicate that one case actually had 2 adults in the APR, 1 male and 1 female, which is why we've got 26 cases. Someone always points this out to me in the presentation. So fairly even in terms of the presentation, I suppose, when you're looking at the proportion, but slightly higher, I would say, female. We had 8 where no age was given as well, which is, again, just some of the challenges we had around coding some of the information within the APRs, which was often missing from the detail of them. Kind of going across into more detail around the cause of death across the APRs that we examined. And again, this is something that we often find is a big discussion point when we've done workshops on this. Quite a high percentage, I would say, and probably something we do need to question, which is how 56% of the APRs, so 14 of them, the cause of death was not clear for us to be able to code it into one of those other categories. With the highest proportion that we could see was from suicide. So when we're going into detail around this, if we're thinking only 7 out of 21, where the result of death was clearly articulated, so just a third of them. So all the others is where we had issues, so that 14 had issues in coding the cause of death around this. Now, what we found when we looked into this often involved potential self-neglect or neglect of others that resulted in death due to the injuries that were sustained. So one of the examples we tend to give to highlight this is APR 4. So this involved a female where no age was given. We know that a family, an ambulance attended the family home, and that individual was admitted to hospital and required emergency surgery. The individual actually had many injuries, including fractured ankles, they had necrotic areas, and then they died later in hospital, only a few days after admission. And then the coroner states within the APR, and it's quoted, died from injuries that were left untreated. A police investigation was mentioned in the report, and it indicated no further action, NFA. This female actually resided at the family home, and their partner had dementia, and they were in receipt of a care package. So they had 4 sort of daily care calls that were happening within the family home. They also had 2 family members providing support within the home. And whilst there were recommendations within the review highlighting issues of self-neglect, which was mentioned numerous times in the report, missed opportunities and the word of omissions from professionals and family members to raise significant safeguarding concerns, these were not clearly stated as contributing to the cause of death. So you can see here some of the challenges we had around being able to articulate really clearly as to the cause of death around this, which again is very, very different to what we see in child practice reviews. So some good discussion points I'd love to have with people later on about why we think this is. We also found, just related to this, that just under half, it was around 44% of the APRs did mention parallel criminal investigations, but again, most of these resulted in no further action. This slide probably isn't surprising. I'll quickly fly through these so we can get to the interesting stuff from Emma. But actually what we often identified within the APRs was this overlapping of risk factors and vulnerabilities and types of abuse. So mental health issues was obviously clearly seen, as you can see on the slide, as the most prevalent factor. But we actually found that 84% did have multiple, so more than one indicator of vulnerability. So it's just worth noting that, as we know from a lot of the cases that we deal with, that there tends to be more than one presenting vulnerability at the time. When we're looking at the type of agency that was involved prior to the incident with the adult, what we found was the GP was the professional sector that was most likely to be engaged with the adult within the APR. And this was closely followed by adult services. Again, this actually aligns with some of the stuff that we have found within the child practice review, which we talk about a little bit later on. So we see around 52% involved in GPs and on the CPRs. We tend to see higher proportion of children's services within there. So again, reflections on why adult services are slightly lower down compared to GPs around this, and what intelligence should and could we be gathering from a GP perspective. We always look at this within the reviews, and we've been really grateful to have great relationships with the SUSR team around this and informing some of their kind of work and monitoring going forward. So it's just worth noting, when you kind of look at the process of APRs, the time frame that actually occurs within this. So what we can see is that from the as you can see, from 24.6 months, that is the average from the incident actually occurring to the learning event. With the learning event, the kind of key opportunity for all those stakeholders, all those professionals to get together to discuss what occurred and to think about actions and learning to be able to take forward to hopefully prevent similar circumstances from happening again. Then when you take the incident of the APR to the sign off of the APR report itself, so to be in the public domain and be able to be discussed by other areas, to learn from that, from other sectors, you're talking on average around 30 months. So again, some real challenges about how do we kind of ensure that we're speeding up the way that we're sharing some of this learning, but at the same time, obviously aware of some of the sensitivities around this. So I'm going to pass to Emma, who's going to go into a bit more detail around some of the key themes that came out from the review.
Thanks, Michelle. So yeah, in regards to sort of the multi-agency response learning, we found 4 key themes. So starting off with the consideration of the whole person, and then moving on to the types of support which was available for them. Then moving on to the collective safeguarding responsibility from all the different agencies involved, and then looking at the wider factors, thinking about workforce, guidance, legislation, investment into services. So first of all, one of the key things that came out is we hear a lot about person-centred approaches and the importance of making sure that the person is involved in their care. But really, we needed to look at how much of this person-centred care was running through the whole safeguarding response. So was what the person really considered important reflected in the assessment? Was it represented in the plan? Did it guide the intervention that they received? Because this wasn't always apparent in all the APRs. You know, and how are we balancing as professionals what support it is that the individual wants, but what support the professional feels is relevant, but also what is actually available and within the certain timeframes that we've got. And crucially, how is this revisited and reviewed? Because we know that people's situations are fluid. So how are we going back to check, actually, is this still relevant? Do we need to be doing something else? And ensuring that that whole person and all of their needs are prioritised throughout the whole plan. So there's examples where in the learning event, for example, there are really rich, detailed descriptions of personality, ambitions, what was important to them. But actually, when you look at the notes and the plans for relation to this person, all of that wasn't on there. So if we're trying to draw all this together, the information was known, but it might not necessarily have been recorded in the key documents. However, there were examples kind of of good practice around this as well. But also balancing that kind of the safeguarding response and looking at what that person needs. Some of the APRs found that there was too much of a focus on kind of practical or logistical things. So this person needs this equipment, we need to follow this process. But actually, it's about the adult themselves, the family, and thinking, well, actually, this is the other thing that's really important to me. And this is what's going to make a difference to my life over and above that. So how are we sort of bringing all of that together? And then for support and engagement. So a big thing that came up when the adult reviews was mental capacity and declined support. So there were real challenges when a referral for support came through, but then the individual did not want to engage with the support that was sort of deemed appropriate for them, but they had mental capacity. And then it was really about sort of unpicking, well, what are the root causes for these decisions and how much of those conversations are evident within the notes? So if we're thinking about things like self-neglect, for example, if a person doesn't want to engage, but they do have capacity, to make those decisions, how do we support them? And in this context, advocacy was really, really important, because if we don't have advocacy, then how are we assured that, a person's wishes and feelings and decisions are really being taken forward? And how are we expecting these people to engage with professionals and disclose all of this personal information when they may be the decision makers, they may not have an ongoing relationship with them? So how are we really using advocacy? And this was quite inconsistent across the APRs. So some APRs said advocacy, was offered at many different points. Every time there was a key decision point, advocacy was offered to this young person, for example, and it wasn't taken up. So that's really transparent. Other APRs had examples where advocacy wasn't mentioned. It was mentioned that it was offered and not taken up, but at one point in time. So when things changed, it wasn't said that it was revisited. And other examples are that it was brought in too late. So, advocacy was brought in at a later point, by which point it was kind of dealing with a crisis, whereas they could have been involved leading up to that, which would have been potentially more effective. And collective safeguarding responsibility. So, there's a lot of different agencies, professionals, particularly health, involved with supporting the adults in the reviews. And what was apparent was, again, information sharing was a challenge, which comes up in all types of reviews. But I suppose, rather than just information being shared, it's important to note that it's the continual sharing of information that is the big key issue. So rather than just reporting concerns, for example, which may have been done, how are we continually sharing this accumulative information to support an adult who may be at risk, and what infrastructure exists for this? So if you're thinking about, for example, sharing notes on a day-to-day basis, if we've got different carers going in, if we've got different professionals doing assessments, if we don't have a central coordinator, for example, an adult at risk plan, a care and support plan, how are we bringing all of this together, and how is all of this information informing referrals, decisions? What is the context around it, the actions, and particularly the follow-up of action? So if we've made an identification of, okay, this person needs this, how is that followed up, and what are then the repercussions from that, and how does that feed into the existing plan? Are we making changes to this plan? And that continual flow of information. And this is made really difficult, when everybody's got different recording systems. We could have people making really detailed notes, and within their own sector or within their own organisation, these notes are widely shared. But how are we able to do that, particularly if it was handheld, for example? How can we share that across different agencies in real time so that we can make really important decisions? And then the sort of wider look of practitioner support, investment and development, policy and protocols. Is there a policy which exists? So, for example, going back to sharing that routine, lower level information of day to day, what's the policy to be able to share that? How do we do that? And if we do have a policy, is everybody aware of it? If you think about turnover of different staff and inductions and different people who are coming in and out of that person's life, is everybody aware of the policies that they need to be? And do they understand the policy? So what is the interaction between the policy and real world? So a person needs a mental capacity assessment. Well, do we know who we need to go to that? Is there a process? Has it been done? Has it been followed up? Has it been revisited? And what are the barriers to be able to implement that? For example, is there a shortage of people who are qualified to be able to go and assess that capacity? So all of these kind of factors will have an impact on how we can keep somebody safe, because they all interrelate with each other. And then, of course, as in every review, workforce issues. So how many, places are dealing with shortages of staff? Are we able to prioritise supervision and support for staff? If everybody's busy and they're running around from place to place, how are we prioritising being able to support our workforce? Recruitment and retention, what are we doing to sustain? Because we know a lot of this is relationship based. How are we able to do that if we've got high turnover of staff? And it needs to be acknowledged that there is a rise in the volume of cases that are being referred and the complexity of cases, and many APRs said, we are dealing with really high caseloads and really high sort of demand for services across the board, which does have an impact. And I suppose, this slide really talks about the commonality, because what we're saying in the APR review has been echoed before. It's certainly been echoed within the child practice review analysis we've done, but also work that Michael Preston Shute has done in England as well on adult practice reviews, and reviews that have been undertaken prior in Wales. There are common themes which come through, and these are things like, systemic challenges, the risk identification, multi-agency collaboration, how we're able to implement the policy that is available. So all of that, there are some kind of commonalities. So I'll just highlight a couple which were evident across this. This is a model health complexity. We actually sort of created this when we did the child practice reviews, which is why it's got the child touch points, but it is absolutely relevant to adults as well. So if this was just to sort of give an indication as to the amount of possible people who are interacting with any adult at any one given time. So you've got the GP at the centre who who should receive a lot of this information, but you've got so many different types of health professionals, whether that's specialists called dementia care, mental health, substance use, or occupational therapy, physiotherapy, all of these different people who are going in to go and do their own job, but how are they interacting, and what infrastructure is available to coordinate all of the relevant information from these professionals and overlay it so that we can get that all important holistic picture of what's going on for that adult. Missed health appointments. So we know that this is a massive issue, and there is an example certainly in children of was not brought policy. But even when we've got such protocols, people can move between areas, and it really raises the question that if this is just one element of intelligence to say, okay, somebody hasn't turned up for this appointment, what is the sort of the mechanisms in place to record all of these missed health appointments? Again, thinking about that health complexity across all of those different agencies, how can we get an overview of missed appointments across all of those different people? How do we collate that? How do we share that? How do we trigger it to say there is a pattern of behavior here, we are worried about this person, what is all of this saying together? Because if we haven't got a system or a mechanism or some kind of ability to oversee all these missed health appointments, then we're going to be struggling to say, what does this mean? So key issues about ownership, accountability, coordination of future action. Well, we may have the information to hand, it's the collation of that and the whose role it is to take that forward to be able to support that person is not always clear. And this is another model which can focus on connections, considerations, complexities, and it kind of just shows really where there are potential avenues for disconnect. So although this says the child in the middle, it could easily be the adult, and then you've got the wider family, and then you've got their environment and their neighborhood and where they live and housing association. So around the outside of all these the three sort of domains of the person, their family, their environment, you have a whole host of agencies, and there could be different professionals from each of one of these agencies. And some of them could be relating to the adults themselves. Some of them could be related to their environment or their wider family. But I suppose what this really does is try and give you an idea of the potential for the amount of information that may be relevant to safeguarding a adult. And how do we bring all of that together, and what are the mechanisms for being able to do that? And when we talk about things like professional curiosity, what do we do with that curiosity, and where does it go, and under which legislation? So I suppose it's just to highlight really all of these different considerations that people need to be aware of and how manageable that is.
I think originally we called this the model of disconnections, but we thought it was too negative. So, but exactly just sums up what Emma's talked about in terms of the myriad of connections. And we even mapped for each one of them, because there'll be someone here that says, how can you have health as one circle? We literally, in the appendix of the report, on the first time of doing this with children, had a whole network that comes off health, similar to what we did before with the GPs, just to show the layers that then sit underneath these as well. Okay, so moving on to the different approach that we took with the APRs. So what we did that was a little bit different, and I suppose it was kind of triggered by a couple of child practice reviews, and particularly within the adult practice reviews, where we got one of our research team, Paige, to look into to try and understand why do we keep getting the same recommendations. And it was something we were really interested in, and we wanted to just dig in a little bit more as to the formulation of recommendations, but asking, that key question, why do we see the same recommendations across reviews repeated time after time? So what Paige did is she did an extremely detailed report, which was looking at the feasibility and quality of the recommendations in the APRs. And then this kind of paved the way for what was the recommendation framework, which we'll talk about in a little bit as well. So I'm going to fly through this because we kind of give a bit more detail about this when we go through the recommendation framework, and I want to leave some time for questions at the end. So essentially what she found was kind of a bit of a qualitative analysis is what she did, and found sort of key themes that really kind of impacted on the feasibility and quality of recommendations. And these were around the clarity and specificity, I love that word, of recommendations, the use of assertive language or lack of, the implications of the recommendations, and the idea of that kind of transparency and realism, as Emma's kind of talked about, how do we implement that? What's the feasibility of actually getting that into practice? These lovely, big, high-level recommendations, but also trying to acknowledge what we can change in the here and the now. So essentially, and again, I'm not going to go into too much detail, but the clarity and specificity was really starting to unpick what was a recommendation trying to say, what was the issue, what needs to be implemented, when does that need to happen, and then who needs to take this forward. And we've got some great examples in the report that you can see, because again, what myself and Emma try to do with all the reports is not just look at what has gone wrong or where the challenges have been, but actually learn from the good practice. So we have got some good practice examples, one in the recommendation guidance, but also in the report itself. And again, just highlights of the other themes, which is around the use of assertive language. Sometimes it isn't appropriate for us to have that kind of assertive language because we are very specific around this being something that Welsh Government may need to take forward or needs to be taken forward as part of a wider system within our regional safeguarding board, for example. However, a lot of the actions could have and should have had more kind of driven, more action orientated language, must and will, which we did see in some recommendations, but very, very rare. And then in terms of implications as well, just trying to understand what would lead to improved outcomes around this. And as I said before, about what can we ensure we're accounting for in recommendations that is realistic to the current situation. Is there a broader recommendation that is at national or regional level, but is there something we can take forward now which can be potentially implemented fairly quick? So I'm going to pass over to Emma just for the last bit to bring this all together. So we kind of highlighted 5 key learning themes from the APRs, which we'll quickly highlight and then just very briefly take you through the recommendation framework.
Yeah, thanks, Michelle. So going back to the sort of themes from before, what was the key learning from this whole person individualized safeguarding? You know, adults' preferences need to be actively sought, recorded and embedded. So whereas they may be known, it's really about sort of bringing that together to say, well, how does that reflect the plan? For example, if we're focusing on, you know, a person who needs to, I don't know, work on certain behaviors or whatever that they feel like need support with, they may need help with their alcohol and drug use, but actually what the person's talking about is the fact that they want to be integrated into education, or for example, and they want to pursue their interests. How are we making sure that those things marry up and that it's about what the person wants as well as what the safeguarding concerns are? So support needs to be really flexible, and how achievable is this with the support offers that we've got? Is there flex to provide that flexible support and that, you know, appropriate support that's for them? And how do we work on, you know, the adult strengths, their ambitions, their support networks? How do we sort of provide that holistic support? And is it available at a time that we need? And there was a good practice example in APR 15 where hospital staff, as well as sort of, you know, prioritising their health needs, they went through This Is Me documentation to make sure their care was really personalised and that their voice was embedded into all decision making. Multi-agency coordination. So when we think about collective responsibility, you know, if we think about that infrastructure again and how we're sharing information with our key partners, really who's got oversight and governance over what those arrangements are? So for example, if we're talking about sharing information and we haven't got the same system, what is in place to be able to share that, whether this is meetups between, you know, certain professionals in order to share that informal information? What are we going to do, and sort of under what plan is that? So the 12 C's responsibility, collective responsibility model sort of gives you key areas to focus. Well, how are we facilitating this joint working and who is accountable for it? And when we think about you know, transparent decision making, ensuring that there are clear escalation pathways, and this really comes down to the following up of information. If a sort of a professional says they're going to do X, Y, and Z, what is in place to ensure that that plan is followed up and that everybody is kept in the loop with that? So there were good examples of getting round, for example, the non-shared database, where social services and district nurses met up. Rather than just talking about one specific case, they would catch up on, you know, real things that could be going on for quite a few different people, so that there was that real-time case discussion to say, okay, well, this is important, this has happened this week, rather than waiting for the crisis to happen. Timely and meaningful advocacy. So as we mentioned before, you know, it's not always consistent in how advocacy is offered. So what are we doing to make sure that it is offered early, that it is explained fully, and that it is revisited? And crucially, how is this in sort of recorded in the notes, so that when we are looking back to say, okay, well, they have been offered advocacy, why did they not choose it at this point? Could we, you know, offer it again? Has the circumstances changed? And making sure that, you know, the adults' rights to representation should be reinforced, you know, through training, through clarity. Is this something that's talked about in supervision? Just making sure it's always on the agenda and detailing that it has been offered and whether it has been accepted or declined, just so that we can ensure that we can revisit this again. So there was examples of good practice where advocacy was repeatedly offered, and they had access to this independent support, and that again this was documented to make sure that we have given, you know, the person the chance to be able to have advocacy. and mental capacity assessments. So, you know, this came up time and time and again, as I sort of mentioned before. So when mental capacity is queried, how are we evidencing this, and what is the decision making around this? So a lot of the APRs might have just said, okay, mental capacity was questioned, but then there's no follow-up to say, well, what did we do about that, and what were the reasons for that, and has a formal assessment been undertaken? And, you know, it can be fluid. So have we revisited it again? And I suppose it's really crucially, it's about documenting all of these conversations all the time, so that when somebody else is picking up that information, they can say exactly where we're up to with mental capacity, and say, you know, we noticed that it can fluctuate, but actually this is where we got up to. Has anything changed? So that everybody can follow on from what somebody else has been doing, rather than just a one-off mental capacity. This person has mental capacity. How can we make sure that we are looking at this in a fluid way? And there were examples where this was revisited and it was documented, and people could follow this on. And this is sort of summarising, I suppose, what Michelle was talking about before. So we noticed that a lot of the recommendations were quite vast. So, for example, agencies need to become better at information sharing, or we need to make sure that there is consistency within the work, you know, the practitioners, and that people are able to build relationships. But really, it's whose responsibility is this, and what are we going to be able to do? And if there is a resource shortage, how can practitioners address that? You know, so it's really about thinking how the recommendations can be made more actionable. So we'll go into, I suppose, looking at the quality of them, and our analysis. As Michelle said, we led the development of a recommendations framework, which we'll talk about in a bit, which can give some pointers, I suppose, to say how can we make the most of our recommendations, so we're not just saying the same thing.
Thanks, Emma. I'm just going to take sort of the last 4 or 5 minutes of the presentation just to kind of give you a little bit of insight into that. We will share the guidance document as well. So initially, Emma developed this kind of framework that you can see on the screen, which is sort of detailed into 7 principles, really, or considerations in terms of, you know, writing recommendations. And within the guidance document, we took this a little bit further and actually sort of prompted with some additional considerations around this. And this comes back to, if you're stripping this right back, you know, I you know, this quote from Dawn was fantastic to kind of really capture, you know, again, thinking about the SUSR process and why we undertake these types of reviews. It's to ensure that, you know, we need to make sure that no opportunity to protect that person from harm was missed, that we can better protect others in the future. So the formulation of those recommendations and the ability to put them in practice and action them is hugely important, and it's a massive part of the process. And one of the things that we kind of reflected on in doing this report, and for all of you that probably write your own reports, whether you are engaged in kind of adult practice or child practice reviews, we all normally have to write recommendations. What are we saying from all of this? And it made us reflect a little bit on how we ourselves haven't been taught how to formulate recommendations. We know how important they are to drive change. We know that they help shape priorities, they guide resource allocation, they sometimes help us change systems and put that evidence together. But as we've kind of put on here, the formulation of them is rarely taught, researched, or even subject to quality assurance. They kind of step after the APRs of going, right, what are the actions to be taken forward from this? Often aren't in the public domain. So we don't quite know or understand, and this is where the SUSR is doing some great work to understand what is taken forward. And how can we ensure that the recommendations are that bridge between understanding, learning, and directing that change? So we, as we kind of put on that, we that are tasked with writing them, we carry that responsibility to ensure that the insights that we've gained are effectively translated into action. So we kind of took this task really seriously, because we reflected on our own work and our own recommendations around this. And so this is where we've got not just the kind of the framework itself of the 7 principles, we've kind of put a whole guidance document together. And yes, we have gone AI on some of the tips around this, just because we're very aware that this is putting more pressure, more work on people. And actually, sometimes what we need is an assist from AI, not to create or write things for us. So with time obviously against us, I'm not going to go into detail because the report will tell you this, and we've kind of outlined the reason why we developed this and the challenges that we saw from the evidence around the lack of clarity, language issues, that accountability not being in the recommendations, and feasibility issues, which obviously led us to these 7 principles with these additional considerations. So what this essentially does is kind of we go through in the document the different 7 principles to kind of make you think about, when you're writing your recommendations, things such as the issue and what is it that the key issue that is being raised within the recommendation. What is the problem we're addressing? What is the intention here? What are we calling for? Are we calling for immediate action? Does it require some structured reflection? Again, this kind of links in with our sort of language as we talked about before. In terms of implications as well, why does this matter? What will the outcome be or not be if we don't or do something? So again, really thinking about the omission of taking something forward as well, and the potential risks or consequences in that. Thinking about implementation as well, which is around, is this doable? What are resources needed? What are the realistic timeframes around that? Asking ourselves what is needed to make this happen and actually continue going forward. Involvement, we talk a lot as well, those learning events sometimes can be great to start thinking more proactively about and collaboratively around who should be involved in the formulation of those recommendations. If you're putting a task on another agency or somebody else to take that forward, has there a conversation happened around that? Again, linking back to that idea of being feasible. So who is responsible and accountable for this going forward? This is where as well, where sometimes AI can assist, and we've seen some really great examples of this within the various reviews that we've undertaken. How does the recommendation that you're stating align with other policy and recommendations? And this is where sometimes you can upload a recent SUSR document or inspection findings and then get it to sieve out some of the things that might be relevant to your recommendation, obviously with the checks and reads, because we know it can also make mistakes. And then the last one, just around impact as well, than just thinking about, how will we know what we've said was worked? Is there something we can potentially put in as a follow-up around this? How will we know that has been actioned effectively? And again, this is just to highlight that what we've got is, this has been built from good practice, and we've got lots of examples within the guidance document around this, around, where we've had clear recommendations that say this must be implemented immediately. Very clear recommendation. There was obviously lots of stuff before that to give the context, but very clear on what the actual time frame were around that. Again, thinking about, what the challenges might be around local knowledge, building trust over time to ensure that we're realistic with some of these recommendations that we're taking forward. We've also included in the guidance document a kind of supplementary checklist that you can pull out and kind of tick through. And this works for both local and national recommendations as well. So it just kind of allows you that sort of checklist to be able to work through. And then the last couple of bits before I kind of close, Jeremy, is just around the AI self-check. So what we've done in the guidance document is that we've created a bit of a kind of a package at the end to then potentially run your recommendations through an AI self-check. So whichever platform, obviously be very careful. And I've put some tips in here around preparing safely, anonymizing, because a lot of the time you find the recommendations are anonymized, they're higher level, but being very sure around your use of that is obviously a key step first. What we've done and what other people have done in using this is actually paste either the guidance document itself, the recommendation document, or just the principles and the template of the 7 principles, and then just given a prompt, as you can see on the screen. Please review these safeguarding recommendations against the following checklist, highlight any gaps or vague phrasing, and suggest clear alternatives. And again, you know, we've got some great examples. And what I would normally do is, and I've done this in workshops, where I take an actual recommendation for an APR and I put it, and you can see I've done an example, but live time, I've run it where I've gone, right, copy and paste that prompt in, and it's run it, and people can see live time what it comes out with and how it strengthens some of those recommendations. And just last bits, obviously, in terms of using AI, we always recommend that you write your thoughts. It's your insights that go first. The whole idea of the AI is to use a template to check that you have accordingly gone through those 7 principles and where they can potentially be strengthened. Again, you can use this opportunity to upload other documents, like I've said, around SUSR guidance, public reports or inspections that you might want to frame into some of your recommendations, a previous public APR report that you might want to link into their recommendations to take it further as well. And again, just ensuring that you do the checks of what the AI returns. And just to end, Jeremy, I promise this is my last slide, is we've had some absolutely fantastic feedback from the SUSR team. You probably won't be able to read this on the screen, but basically what this is saying is they use the AI, firstly inputted the recommendations to the reviewers, and then what they did was they the AI provided structured scoring and feedback, highlighting areas of strength and identifying where improvements were needed. And the AI flagged recommendations where the issue was not clearly articulated or where implementation plans lacked realistic timeframes. And then this person who used it said the process helped to enhance the consistency, ensuring each recommendation was actionable. AI's ability to interpret and apply the framework criteria has helped to create clearer, more impactful safeguarding recommendations. So it's just to give you a bit of insight of the feedback that we've already received around that, which hopefully will help people in their own reports. And I think, Jeremy, we are done.
Brilliant. Thank you very much for that, Michelle and Emma. That was really interesting. And we have a couple of questions already, but if people have more questions, then please do take the opportunity to put those in the Q&A box. So while people are doing that, I'll ask the couple that are here, and I've also got one I wanted to ask myself. So this is from Kelly Morgan. They said, they would be interested to know how many of the 25 instances have been subject to work-related death protocols.
Ooh, I don't remember seeing that at all, Emma mentioned.
No, I don't at all.
It's something we can certainly take away, Kelly. Yeah, but I don't remember seeing any of them.
Okay.
No.
Yeah, thank you for that. So the next question is from Caris Phillips, Caris says 2 serious case reviews took place in 2015 after 2 people with serious learning disabilities died. The very first recommendation in both serious case reviews was that continuing healthcare be considered regularly to prevent harm, neglect, or even death due to not having complex needs assessed appropriately. And the question is, are there any correlations with the reviews that you've looked at here?
Okay. Thank you for the link, by the way. And Caris, feel free to drop us an email. I don't think this was one that was included in our APR.
No.
Yeah, and I think this comes back to your points before, Emma. You know, when you're talking about to prevent harm, neglect, or even death due to not having the complex needs assessed appropriately. So one is to reflect on the descriptive data, which tells us that the presentation of overlapping complex needs is present in around 80% of the cases that we reviewed. So a really high proportion of the cases that result in a large proportion, obviously, that resulted in death around this. I don't remember sort of seeing, and again, Emma, you can come back to me on around this, but we can do some checks. But certainly it's not come out as a theme, otherwise we would have picked it up around continuing healthcare. Be considered, because we would have picked that up. I think the challenge that we've identified, and we've had some really good conversations with NHS Wales around this, which is the real challenge around health. And as we've kind of shown, the kind of complex health needs that we often see, and how Emma talked through that kind of spiral of connectivity that should be present, but actually is just so hard to patch in into lifetime information. So, you know, the reason why we always bring the was not brought policy and protocol into conversations is because that in itself would seem like a very basic thing to be able to implement. It seems very sensible to have that. But what we see as the challenges, just from a very basic principle of someone not attended, and that can potentially just be a tick box or not, even the sharing of that information is not making its way through the system. So the challenge that we've got is, even when it's more complex information, if we're not even able to share attendance and people not being visible or absent from required or, you know, necessary appointments, because as Emma pointed out, they're across different healthcare kind of providers, agencies, that we've got a real challenge around information sharing, and we need to go further with that. So we are having some really meaningful conversations with Public Health Wales and the NHS Wales around how we need to be just really brave around how we try and get around this. And as we've shown in Emma's kind of best sort of good practice highlights, was going back to old school stuff, wasn't it, Emma, about bringing people together physically to be able to try and overcome some of those issues.
Yeah, and I think it's also that, you know, the idea of sort of continuing and different types of complex health, it's about ownership of that information, isn't it? Before necessarily, if you're talking about preventing harm and neglect, so before it gets to the point where it is a safeguarding issue, it's who's joining up all of that and coordinating all of this to prevent. So you get a lot of different people, particularly the more complex the case, supporting a lot of different aspects. But it might be that all of those assessments are spot on, but the sort of interrelated and interaction between different things is where the challenges are. So we really need to think about accountability. And I suppose that's where your collective safeguarding comes in, to think about what are those underpinning structures for being able to have those conversations between different professionals and have those checks to say, what does this accumulative information look like, and where are the potential, you know, issues ahead, and what can we do as a collective, which is really challenging within health because of simply the size, I think, of the organization and the different, you know, not everybody's based in one building, not everybody's based in the same, even though we term it same organization, it's not. So I think it's really, there's definitely parallels in that kind of complexity of health and how we bring that together.
And I think, Jeremy, this probably links in with the point from Bethan as well, because one of the things I was going to mention was around advocacy. Because obviously, Caris, you mentioned around, you know, learning disabled, and, you know, the cases where we talk about advocacy and how, because, you know, we think about, you know, from children's, how do we ensure that we're capturing their voice? But when there's challenges around capturing adult voice, the advocacy is a huge part of that. As Emma's kind of talked about, the variation is to, you know, it's almost impossible to figure out how it's delivered because we record it so poorly. So, you know, it could be happening effectively in one area, and we've got some very specific recommendations around advocacy, and almost having a kind of advocacy coordinator within local authorities to give that oversight as to how advocacy is being offered and monitored and recorded, because we only know about it if it's recorded. This is the unfortunate situation we're in. So kind of going back to the point of Caris around these cases and how advocacy is offered, you know, in cases where we've got some kind of disability or communication needs. And then Bethan's comment around, you know, that advocacy for their family, for their carers, for their, you know, who it is taking responsibility. How is that offered and captured as part of these models? And so that's why we've sort of said that responsibility needs to be a very specific role, where again, accountability is in the system to be able to ensure that we're monitoring that and recording it appropriately, so we can follow through with some of those actions when we know that there's some challenges in that area.
Yeah, I mean, I was going to ask a similar question, really, which from what you're saying, you may not be able to answer because it doesn't sound like it's been recorded, but I guess my query was under which provisions is advocacy offered, because there's not a kind of safeguarding advocacy service per se. You would get advocacy offered under the Social Services and Wellbeing Wales Act or the Mental Capacity Act, or under the Mental Health Act in some cases for people who are being detained. So it kind of comes through multiple provisions, and then there might also be some, general advocacy services which are commissioned, or they may not be, depending on the area. So it can be quite difficult for people to navigate, and it's not necessarily clear how it would be flagged up to people who are part of the safeguarding system.
Yeah. Again, it comes down to the points you raised before, Emma, about, I think it's about awareness. So one is, we constantly talk about mapping, don't we, a lot of time in safeguarding. How do we know what services, advocacy services, or, if you're talking about drug and alcohol, whatever kind of support services, how do we keep live to the different agencies, partners, referral agencies that are available in our area is a challenge in itself. And I think that's one of the things that certainly we've kind of had conversations with the Older Persons Commission around this, which is how do we keep live to what is available, and without demand over the kind of the demand of the system as well. Because once you say, here, we've got a service, it will very, very quickly become overwhelmed. So there's some real challenges, and the only solution to this is further and much more commissioning and much more scrutiny and monitoring around how this is utilised, because we know with everything that it's a huge part of, voice has been a huge part of this project, and we've got a very deep dive work that Emma's leading on at the moment to look at children and how we advocate for children around this, because we talk about voice, we talk about meaningful engagement, but we are quite poor at being able to evidence that we're doing it. So we're really hoping to kind of push that forward a little bit more, but it does take resourcing, and this is the challenge around recommendations around this, is first understanding what is available, hence why we've talked about a lead for advocacy at local authority level or at regional safeguarding board level, to at least understand what is available and how are you actually doing this. And then feeding this into like things such, Jeremy, like their annual safeguarding reports. Why are we not, when we're talking about voice and lived experience, which is one of the 5 domains in our kind of 5 domains for safeguarding effectiveness, where are you and how are you engaging in that advocacy and that voice? And it should be part and parcel of the reporting mechanisms that are in there.
Brilliant. I'm just aware of the time, actually, because we've got maybe about 3 minutes left, and there's 2 questions. So I'll ask the 2 that are here, and then if you are able to answer them quickly, if that's possible, that would be good. So the first one is very quick, which is repeat safeguarding referrals. Was this a feature? And I'll just ask the second one as well, just so you can do them both together. So Sarah Jane Evans here says, I've worked in the sector for 23 years, and the conversations have always been about different people using different information capturing systems which don't talk to each other. And it continues. This seems to be one of the biggest and thorniest issues, which in these digital times you would think could be solved. So it's more a comment, really, but if you've got any issues that you might reflect on around that. So there may be extra questions, but I think we're going to have to draw a line under it there just because of time constraints, people. But over to you, Michelle and Emma.
Yeah, I think it is. I mean, you would think, you think about the things that people are doing in the private sector with regards to technology and sharing, being able to share information, but there is still, I think there's a lot of confusion, and still, even, with legislation of what we can share, when we can share it. But also it still comes down to the idea of sort of coordination. Somebody has to bring that information together. Somebody has to search, even if you did have a shared database. So it needs to be somebody's role to be able to analyze all that information, bring it together and say, what does this mean? And so it's almost a care coordinator role of information. So I think there's always advancements in sort of technology, but in terms of consistency in that and the resource to standardize it, we're not there. Although it's something that we do keep sort of arguing for. We argued for it with the police, not us per se, but generally, and they managed to get the PND. So you would hope that there was a way forward, but obviously there is a lot of kind of complexities with personal information. But I suppose it's about thinking, well, what can we do over and above that? If we can identify from a local level, an organizational level, from a safeguarding partnership level, which bits are we struggling with, and how can we locally overcome that? I suppose is a key thing that we need to do in the interim time, because there might well be technology, but we've got the resource or the access to it? Not always.
Great.
And there is repeats. There's lots of repeats. Hence, the extended proportion means that they're already known in the system. They're already engaging with statutory services, have already reached that threshold. So there's definitely evidence of repeat referrals within the APRs.
Okay, well, thank you ever so much for answering all those questions and for a great presentation. It's been great to hear what you've got to say, and really interesting. So thank you to all of you, the audience, for attending. If you would like to see more of the Safeguarding Adults presentations, do go online to Exchange, and the recordings will be online if you would like to access them as well, and also our podcasts. So thanks very much, everybody, and hope to see you at the next Exchange conference.
Thank you.